Lockie's going to take control of today and be the host. Lockie, as I just introduced, is the head of corporate special projects at ICS, which is a data company. We've now been the software that we developed has been now sold into another company, and they're doing a lot of data analytics around a whole range of special AI projects, which is going to help the industry from being able to map trends in impairment assessments to being able to assist doctors doing surgery to make sure that their quotes are correct. We're working on these projects with your underwriters, you'll be pleased to know, doctors. I know that APRA are now really becoming a bit of a thorn in the side of some of the insurance underwriters, and to assist in making sure that everything from a medical treatment point of view gets done properly. We've started building these AI tools. So I'm going to say thank you, Geoff, for today. Thank you very much for your time. You've always been very generous to MAG and very generous to the industry with your time. I do recall a few years ago when we did a presentation to Allianz to about 100 people, and you had them rolling in the aisles. So I'm sure, apart from the factual content and the relevance to the medico-legal world that your presentation will be, it'll also be very entertaining. And thank you on behalf of the participants. Right, Lockie, you're going to have to take charge of turning off all everyone's microphones.
Mark, you might want to make me the host as well, so I can mute people as required if things do come up.
Yeah, where do I make you the host, Lock?
You go into participants on the bottom screen, and then you go more against my name, and then make the host.
Okay. Thank you so much for that. I'll just contact that line and then call you back. Thank you.
Gotcha. Yep. Thanks, Lock. Okay, so yeah, thanks again, Geoff. Your time is very valuable, and you're committed to education of CMs in the industry, your colleagues as well, and the lawyers who have logged on. So, with your permission, also we'll distribute today's presentation, only obviously with your permission.
Yeah, that's fine.
And we know that there's been quite a few registered for today, so we'll distribute that afterwards, and I'll talk to you again soon. So, Locke, over to you. Thanks, Geoff. I'm going to bow out because I've got to go, unfortunately, to my great uncle who bailed me out a few times funeral. Thanks again, everybody. Have a great presentation. Bye-bye.
Yeah, give up.
Thanks, mate.
Thanks, Mark. So I might just share my screen very briefly, if that's okay with you, Geoff, and just run through a couple of the projects that ICS is working on. Yep. So, as Mark mentioned, ICS is a data and analytics company that's working on providing software solutions to the insurance and compensation services industry. So we're delivering a range of software solutions, and we provide a leading workflow management system for personal injury stakeholders. But quite interestingly, we're working on some AI tools to assist both law firms and insurance agencies to make better decisions around assisting injured people in getting back to work. These integrated data and analytics tools are proving quite useful in increasing return to work rates and decreasing times in which people are outside of the workforce. So we're working on some clients specifics or client sector specific platforms. So working on assisting some law firms with our Law Connect platform to work better with their clients. We're assisting some insurance agencies using the ICS Insure Connect platform which provides a full panel management functionality service, a workflow and correspondence management, and integrated telehealth solution. And all of these sector-specific platforms include our integrated data tools to assist claims managers and lawyers to make those decisions faster and more accurately. Also working with some government agencies on allowing them to manage their compensation claims at an excellent service standard. And so using that worker communication solution and those integrated tools to improve the return to work outcomes and providing government agencies with a fully compliant document exchange platform. As Mark mentioned, some of the most interesting, I guess, work that ICS is doing is around our artificial intelligence and machine learning and taking tens of thousands of lines of data to better understand claims leakage within the industry, to better understand financial calculations, to better understand injury management, and how we can assist law firms, insurance agencies, government bodies, and really all stakeholders to better assist the injured person in returning to returning to the workplace, getting back on the road, and improving their injury management. So that's all I'll say for today, and I'll stop sharing and pass over to Geoff.
Right. Okay. Lockie, to show my slides, do I have to hit share screen?
That's right. The green button on the bottom of the screen.
Okay. And hopefully that'll come up. Okay. Can everyone see my screen now?
Yes. And Geoff, you might just want to, in PowerPoint, if you click on slideshow in the top bar.
Hang on. Oh, slideshow, yeah.
Yep. And then go from beginning on the left-hand side.
Gosh, lucky you're here. Lucky you're here. How would you survive without a mobile phone and a computer?
No, it's impossible.
I remember doing neurosurgery for 6 months on call, and there was no mobile phones. There was public telephones. There was pages. So I knew every phone in the eastern suburbs of Sydney that worked and didn't work, or was full of change or not. It's just a different world. And you could never be far from a phone that didn't work.
How times have changed.
Yes, very much so. All right. I know there's a few doctors and I know there's some non-medical people. So I shall hopefully talk to everyone. As you know, don't know, I'm an orthopaedic surgeon. I mainly do spine surgery for my sins. But I still do some hip and knee. So I sort of still have knowledge. So I sort of look at it maybe an all-encompassing perspective. Anyway, I'm mainly going to talk. I mean, I can talk about fusion a bit too, but mainly the thing is with fusion. So certainly in the States, historically in the States, people turn up to their doctor and they expect surgery. And if you don't offer them surgery, they'll get irritated and walk on down the corridor to the next bloke. Much the same here. People turn up to their GP expecting to get antibiotics for the flu, and if you don't give it to them, they'll go to the next guy. Whereas in the States, particularly in this town, most people would rather chop their arm off than have any sort of spinal surgery. It's really a last resort. Anyway, moving on from that, on the assumption that you do help a lot of people, and the main thing, the parameters are that I can improve you, I can't cure you. People will slam the table demanding, do you give me 100% guarantee? And the only 100% guarantee I give is that I'll do the best surgery I can. As all of you gentlemen and ladies know, really it's up to the patient how they recover. So early in my career, I used to think I was the rate limiting step. It's not, it's the patient. It's the patient. So everyone gets told, I'll do the best I can. How quickly you get better, how well you do is up to you. And if you ever come and see me and post-operatively I start talking about the bell curve, I'm really irritated. But what piqued my interest in SI joint problems, and we're still a bit behind here, like in the States, where really is the center of the universe for all this, it's a no-brainer. But they're probably too aggressive the other way. If you don't run fast enough, they'll operate on you. But I had a lot of people coming back and they've had successful surgery technically. They seem to, everything looks all right. They're better than they were. And usually at about the 6-month marks, but sometimes it's later, they suddenly come back and they've got this non-specific low back pain. And you think, well, that's a bit odd. And maybe it's just, I was never going to cure your back pain, but I was going to improve it. But then they started getting groin pain. And in my world, groin pain could be from your hip, could be from your lowest disc, but I fused the lowest disc. It could be from number L23 disc, but L23 looks all right. So what else could be going on? And in fact, it's sacroiliac joint pain. Now, the old teaching to us was always sacroiliac joint pain per se. It's from the spine until proven otherwise. But these are people who have had successful spinal fusion, technically successful anyway, and yet they still got problems. No, hang on, do I do this? Yes. So there's a psychological term which I forget, but it's when something comes in your across your radar, you see it everywhere. And I see it a lot of the time. In fact, I'm lucky because some of my peers, particularly neurosurgical peers, still struggle with the concept. So often they will triage people who they think might have sacroiliac joint problems and then send it to me for surgery. So that's really good. But it's just briefly what I'm going to talk about is the causes of sacroiliac joint problems in my world, how you diagnose it, what investigations you do, and the treatment. So for me, the overwhelming majority of people, it's adjacent segment disease. We know when we do a solid fusion, it puts extra pressure over the adjacent segment, which we've always thought historically was proximally. And in fact, there are some people who are so terrified of having fusions because out there they believe that yes, you'll then get on a treadmill and a few years later you'll have to have the next level fused, and then a few years later the next level fused, like a house of cards. Like what was that thing where they thought communism was going to overtake Southeast Asia, the domino effect? Anyway, but no one ever thought distally, because the sacroiliac joint is not a joint that moves like the hip or a spinal motion segment. It's partly synovial and partly fibrous. But in fact, it does get symptomatic. And the overwhelming majority of people I see, it's adjacent segment problems. So for me, it's quite simple now, whereas 10 years ago, I struggled with it all. You do have people, typically prolonged, protracted childbirth, prolonged labour, very large babies being sort of fiddling with the pelvis, trauma, because pelvic trauma, the pelvis is a ring, you get some sort of disruption, rotational or vertical shift, it does affect the sacroiliac joints. And then in the old days, iatrogenic, when one in the old days before my time used to do spinal surgery, surgeons used to do a separate incision, take half the back of the posterior iliac crest as bone graft and lay it in. And by God, they got good fusions, but a lot of the time they disrupted the sacroiliac joint doing it. But I'm very dubious about people turning up with sacroiliac joint problems out of the blue. It gets diagnosed a lot by sports physicians, my colleagues, by physios, but it just doesn't happen out of the blue. Yes, occasionally someone can slip and have a fall and twist it, but the overwhelming majority of the time, it's adjacent segment problems in my world. So, I've had a few sort of discussions through letters and emails with case managers, like how does this relate to their original injury? The original injury was accepted as a work problem. It's had been treated successfully, but now they've got these problems as adjacent segment overload, and I'll come back to that. Overall, there's now quite elegant studies done that show you've probably got after a successful spinal fusion, you've probably got over a 10-year period, a 10% chance of getting symptomatic enough that level will wear out, requiring surgical intervention. But that's not in everyone. It's mainly in older people who are riddled with degenerative change, people who have multiple operations, people who have a very long construct, a multi-level fusion, not 1 or 2 levels, but much longer, and people who have had a long fusion, then do a laminectomy above it. They sort of wear out fairly quickly. But having said that, the exception to the rule is I saw 2 people on Tuesday who have had no spinal surgery, and both, I'm absolutely convinced, have sacroiliac joint problems, because they do. So these are some very good biomechanical studies, and when you fuse sacroiliac joint, it puts extra stress on your hip, and it puts a little bit of extra stress on your lower adjacent segments in the spine. But have a look at the reverse. Okay, if you fuse 1 level in the spine, you get 52% extra motion and stress through the SIJ. You fuse 2 levels, it's 168%. Okay, so I'm not trying to suggest and alarm everyone that there's now a flood of sacroiliac joint problems going to happen. There's not. And yet, despite this, you just don't get much extra pressure on the hip. There's a whole lot of studies, whole lot of studies, and you know, and as I said, the more segments you fuse, the incidence of SIJ problems increases. But in my world, I mean, the majority of people we're doing, they have 1 or 2 level fusions, and there's about a 10% incidence. The other thing is too, time-wise, it sometimes happens quickly and within 6 months, and other times it happens a few years later. So I've just recently got approval to do a lady fuse her SI joint that both of them become symptomatic. And I think I did her original fusion 15 years ago and hadn't seen her since. And, you know, so she'd be doing all right. So when people don't come back, they either hate my guts or else they're doing well. And I'd like to think the latter. Just another slide showing much the same. You get increased motion and stress through the SIJ and increased incidence of sacroiliac joint pain and problems. And obviously, the more levels that are fused, the more this increases. Same again. Just all these slides I found on the website, but it's showing much the same. So this was interesting that here up to 43% of people who are symptomatic post lumbar fusion, it's because of sacroiliac joint problems. So please, Mr. and Mrs. Case Manager, don't panic thinking that every single fusion we do is going to need a subsequent sacroiliac joint fusion. Not telling you that. That's not the take-home message. And there's still a lot of my colleagues, the dreaded IME, the independent medical expert. It's much better than it used to be, but someone like me who primarily does spinal surgery and being an orthopedic surgeon, I just get sent over 90% of the spinal surgery I do, I'm instrumenting because that's what I see, not because I'm aggressive. I mean, the simple chip shot laminectomies, discectomies, by and large get sent to neurosurgeons because that's who the GPs think do spine surgery. And by and large, that's pretty true. Whereas a generation ago, there weren't many neurosurgeons doing spine. It was mainly the domain of orthopedic surgeons. So once again, remember, you're treating the patient on the X-ray. Up to 40% of radiological findings are incidental. So just because they do have some degeneration in their sacroiliac joint, it doesn't mean that they're symptomatic. But it's a real thing. It happens. And once again, the more levels you fuse, the greater the stress transfer to the adjacent segment. So in my experience, remember I said groin pain. In my world, groin pain can be from the hip. So I disagree with one of these slides. It can be from the hip, it can be from the lowest disc, and it can be from the sacroiliac joint. And I got to tell you, if they don't have groin pain, it's not their sacroiliac joint. I've yet to see anyone who does not have groin pain. And to me, that's almost a given that they must have that. They often can get leg pain, but typically in an L5 distribution, because you've got lumbosacral trunk running over the front of the SIJ. And so they get a bit of inflammation, irritation affecting that, and they can get L5, S1-ish symptoms. So once again, you know, you do a lot of investigating, make sure a piece of disc or bone or something hasn't come out that's causing this, that it's not spinal, because you need to exclude that. But they can, plenty of these people, and often it's bilateral. The teaching is, once again, from they, whoever the mysterious they are, don't do two simultaneously. Do the more symptomatic one, and a lot of the time, the other side will sort of improve or settle that it's manageable. So they get back pain, but usually it's in their buttock. They can get leg pain, as I said. They can get pain in a quasi-dermatomal distribution, typically in the buttock, down the side or back of the thigh, below the knee, can go to the calf. In an L5 distribution, occasionally the back of the calf and S1, they can get some numbness and they can feel a bit weak. Typically, they can't sit too long. They're often like someone with hemorrhoids or a big disc. They're sort of sitting on the side of the chair like that. They have terrible pain in bed at night. They can't stand still for too long either, all right? And they always, 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 as far as I'm concerned, have groin pain. So when you examine them, primarily, there's nothing much to find in their back. A good test, you ask them, I think it's called the Fortin finger test. Put a finger where it's most sore, not sort of rub all over one finger where it's sore. And typically they'll point to their SI joint. There's a bunch of provocative tests. And once again, the parameters for diagnosing is that you need at least 3 of them to be positive out of 5. And when they're positive, they jump off the bed. I'm not going to demonstrate them on myself. It's a bit difficult. Investigations. Obviously, I like an X-ray, just because I do. A CT scan, that can help. An MRI scan can help. A bone scan can help. A bone scan, particularly excluding significant spinal pathology, and also diagnostic injection, diagnostic and palliative. All right. So in the ideal world, they've got a hot bone scan. I mean, you're thinking they've got SI joint problems. Their bone scan is hot. Their MRI scan is, positive. They have an injection and they're terrific for 3 months. And then they come back, they have another injection. It's not as good, lasts about 2 months. And then usually they say, I'm sick of this. I want you to do something definitive. So here's the story. When I first started doing these, I remember some hotshot from America was sitting just opposite where I am now. And he was an orthopedic spine surgeon. I said, so how many of your people, I mean, this stuff is rubbish, isn't it? How many of the bone scans and everything are hot? He said, very few. And I said, how many of your patients get significant relief for 3 months with an injection? He said, very few. I said, so why do you print all this rubbish? Because Americans bullshit. But anyway, the reality is, and once again, it's hard for the case managers because, I send a lot of people, I think it's a clinical diagnosis, and it's always nice if it's backed up, but you get people, they might have had an MRI scan post-op to show that the spine is fine and the SI joints are okay, and it's negative. They have a bone scan, it doesn't show much at all. They have an injection, it doesn't help much at all. And they say, well, how do you know it's the SI joint? Why would we approve treatment? And I understand that. So the reality is with the injections, even if they don't work, and I've learned this over the time, I ask them, all right, but when you had it, where you had it, did it hurt? Yes. Was it your typical pain? Yes. So it's like a discogram. Often they're quite provocative. Or occasionally I saw someone recently who didn't hurt at the time, but within half an hour, they had their typical pain. And once again, that can happen with the discogram. They're in and out, but they're sitting in the waiting room half an hour later and it's really, really sore. It's been a provocative test. So it's hard. It's hard. I mean, the very, very, very first SI joint fusion I did, she had a hot adjacent segment problem. She had a hot bone scan. She got 3 months of relief with the first injection. She had 2 months of relief with the second injection, then said, I'm sick of injections, want you to operate. And that's the only one that's been like that. Most of them get a bit of relief, but it doesn't last. So you can try a whole lot of non-operative treatment. I'm a bit dubious, but I mean, I don't sort of say I'm the only one that can help. So you must rush in and have surgery. I sort of phrase myself as a last resort. If your symptoms are unmanageable, nothing much is helping, it's reasonable to contemplate surgery. So, some physios suggest you do exercise to strengthen your hip external rotators and these and that and the other, but a lot of them, doesn't help. There are sort of cumbersome type braces that can sort of immobilize it a little bit. People don't like that, just overall strengthening and injections. But really definitive treatment, if that's what they got and their symptoms are unmanageable, is to fuse the joint. And overall, come all takers and all things, if you've got the diagnosis right, initially they're pretty good, but about a third of their pain drifts back. But they're about 70% better in the wash-up, plus or minus. But most of them are very happy they've had it done. Not, oh, well, you tried your best, we had to do something. But no, it has made a difference. And the typical thing, as I said, they've always got groin pain and they really have trouble lying on their backs, in the supine position in bed at night. And they wake up in recovery and if they wake up, but when they wake up and when they're awake enough, I say, so how are you? So my groin pain is gone and I can lie flat on my back. So I know they're the ones that they're going to do well. But there are some of my colleagues in this town who just think people like me who do this are cowboys. We're just operating for the sake of it. It's not proven. It's not nothing. And we're really, and then you go in the good old days when one could actually travel and go to meetings in the States. But people would sort of say to me, you still argue about stuff like this, or you still argue about aspects of spinal surgery. They're more aggressive than us, but that's because their population of patients is, demands treatment. But that's not to suggest they're over-treating. But I think, sometimes under-treat. So there's all sorts of ways you can do it. I use this. I'm not advertising anything. I'm not going to tell you what this is. But basically, for me, it's minimally invasive. You make a small incision in the buttock. and then I use X-ray. I don't use navigation. I don't use robots. I'm not poo-pooing anyone who does. I don't. I'm an orthopedic surgeon. I grew up pinning things and putting screws across things as part of my trauma training. So instead of pinning the hip, I'm pinning the SI joint. I tend to do these on a Friday when I have my training registrar. I'll put the first wire in and then obviously stay there, scrub, and let the registrars do it. So, you know, and everyone's surprised with good X-ray, it's good. I mean, what are the risks? You can come a bit close to the exit foramen and prang a nerve. I've done that once. If you're not careful, the guide wire can come out the front. You've got branches of the sacral plexus. You can cause a hematoma. If you're really having a bad day and coming too far anterior, you can perforate the rectum. But I do it with them lying prone on a Jackson table. Everything falls out of the way. So for me, by and large, this is truly a minimally invasive operation. I keep them in for overnight. Occasionally I have to throw them out after 2 nights. They might get a bit of buttock swelling and discomfort, but overall I'm very happy with it. I'm very happy with it. So the hard thing, and I do occasionally get sent people from neurosurgeons who think it might be SI joint pain, and I got to say most of them don't. It's not. So just because they send them to me doesn't mean I agree with them and operate on it. So that's one system that's available. There's a system I used to use where you put these big screws across. There's other systems where you're coming in from behind. Can you see, here's my pelvis. And you actually are doing a more direct posterior incision. I think that's more disruptive and more painful. And basically you get in and buggerize the joint and put a big blocker in it or bone graft in it. I don't do that. I just do it all. I don't see the joint. I do it under X-ray control and it works for me. And, you know, people ask how many you've done. I don't know. I've done plenty. But I think I've seen about 5 this week. It comes in runs. I've got to give a talk to you, gentlemen and ladies. And suddenly every man and his dog seems to have SI joint problems. So I guess in this setting of particularly work-related injuries, the overwhelming majority of people, it's adjacent segment problems below a solid lumbar fusion, usually 1 or 2 level. And it's a real thing. And it'd always be nice if I mean, the examination is fairly standard, but often, as I said, I don't get disheartened. I used to, by the lack of objective evidence on radiology, particularly a bone scan, and the fact that an injection doesn't help them. It'd be nice if it did, but at the end of the day, you just got to go with your judgment. So I don't have a great deal more to say about it. I mean, I can keep rambling on. I mean, does anyone have any questions? Is it sort of beyond the pale? Are you all outraged by my contentions that it's a real entity?
Are there any, and if there are, feel free to add questions into the chat as well and we can read them from there if there are any questions for Dr. Rosenberg. Got a question from Brian, Dr. Rosenberg. Do you see many veteran clients?
I don't, but I don't. Not because I don't want to. I got one guy who's a vet, who in fact I'm seeing on Monday, who I recently had to extend a fusion up in his thoracic spine, but not SI joint problems. But do I see veterans? There's a question me, do I see veterans patients? See, this is excellent service. Thank you very much. I mean, I'll see anyone. I'll see anyone. It's interesting because I left the public system 8 years ago because I did my 17 years and made way for a younger person. But I still see everyone. In Sydney in particular, it's not like in Melbourne where if you, God help you, if you're uninsured, you don't set foot into His Majesty's rooms. But here we see all comers, and that's a good triage because people know I can't operate on them in a public hospital because I don't work there anymore. So that triage has got rid of a lot of the write me up for a disability pension or I want a parking sticker, stuff like that. So but if the question means do I see vets? Yes, I do, but I don't tend to see many for no particular reason because they're not sent to me.
Can I speak?
Yes.
Can I speak?
Yeah.
Can you hear me?
Yes, I can.
Yes, we can hear you, Dr. Hopcroft.
Excellent presentation, Geoff, and I agree with so much of what you've said. A couple of things come up. Number one, the young person with a unilateral sacroiliac joint fracture that gets stabilised perhaps with 1 or 2 screws.
Yep.
Should you later on take those screws out because they seem to develop pain on the contralateral side? That's the unoperated side.
Okay.
If they're not taken out. That's my first question.
Yeah, it's a good question. I could sort of argue it empirically, and it makes sense, but I don't have experience of that because I don't work in the big trauma units. But a lot of the time, per se, the screws come loose. They work their way loose anyway and seem to be a pain generator. But there's no reason you can't take it out once the fracture is healed.
Yes, this was a case of a young girl under Stephen Ruff's care out in Dubbo, and she came to me with pain in the unoperated side, so I sent her back to him to have it out. The other thing, Geoff, is gout is just such a pandemic of itself now with so much drinking going on. And it seems that patients generally don't like to be honest about how much they're drinking. So I've got to the stage where people coming in with back pain, I almost routinely do a serum uric acid.
Really?
And I had one just in this last week. His serum uric acid 0.59, an injection into the sacroiliac joint solved his problem, and he had had a double level fusion, L34, L45 leading L5S1 out. And he was really crippled with his pain, and it was quite obviously coming from the sacroiliac joint. So I just say to the group that I think serum uric acids should go onto that list of things to be done, because Geoff is absolutely right in saying the sacroiliac joint problem is so often overlooked in the management of the back pain problem, people focusing on the intervertebral discs and the facet joints.
Yeah, no, well said.
We have another question from Brian, Dr. Rosenberg, and he's asked, is there a typical common type of injury
That affects the sacroiliac joint?
Yeah, I believe so.
Yeah, I guess I've had one or two who typically, I mean, you know, I'm leaving fractures and stuff like that out of it, and pelvic fractures. I've had a couple who, and once again, I thought it was the spine, but it wasn't the spine. They've sort of caught their foot in a rubber mat working behind a bar or something, or in a service area, and they've twisted on their leg and then fallen down. So rather than break their hip, because their bones are strong enough, they've sort of disrupted their SI joint. They haven't disrupted it by landing heavily on it, but they sort of twisted it that way. So I have seen it, but it's anecdotal, not scientific. The majority, I'll keep saying and banging and hammering on about it, the majority of who I see have had spinal surgery, have had spinal fusion. And Alan, to your point, I'm always a bit worried when, and I see a steady supply of referrals from my neurosurgical colleagues. They've had typically a 4-5 fusion or a 3 to 5 fusion, and they've left the lumbosacral level out, and they now have groin pain, a bit of discomfort, and they wonder whether it's SI joint. And just about all of those ones I've seen actually have instability. They've developed a spondy at lumbosacral level and a very degenerate disc. And I sort of write back to them saying, listen, it might be SI joint, you can inject it. If they get excellent relief, sure, but usually you'll find they won't. I think you need to treat the lumbosacral level. The adjacent segment hasn't skipped that lumbosacral in that setting.
Are there any other questions from anyone at the moment? And if there's questions that come up later, please feel free to email them through, and we can always pass them on to Dr. Rosenberg. I think that might be all for today. Thanks very much again, Dr. Rosenberg, for your time and for taking the time out to present to everyone. It's very much appreciated. And to all those who have attended, we'll be sending out these slides to yourselves after the presentation today. So thanks again, Dr. Rosenberg, for the presentation. Very insightful as usual, and look forward to the next one.
Okay. All right. Thank you all for dialing in.
Thanks, everyone.
Cheers.
Have a lovely day.
Okay. Bye-bye.